Good evening, everybody. Just wanted to let you know that we are letting people filter in now, and we will start the presentation at 5.
Corey, can you hear me?
Yes.
Corey, there are babies.
Oh, we'll have to contact her and say congratulations.
We have babies.
Okay, it is 5 o'clock, so we'll get started. Welcome to the Department of Health feedback sessions regarding behavioral health licensing. Thank you very much for joining us today. Please be advised we are recording this meeting. My name is Corey Tarswell. I'm the Strategic Policy Manager for Health Systems Quality Assurance at the Department of Health, and I will be facilitating today's feedback session. I use she, her pronouns. I am a white woman with brown hair pulled back tight against my head into a braid. I'm wearing a bright yellow shirt with sort of a faux lace neckline. And my background for this Zoom is a winterscape of snow-covered trees on the mountaintops. I'm joining this webinar from Olympia on the ancestral unceded lands of the tribes we know today as the Squaxin, Cowlitz, and Nisqually. I honor and thank their ancestors and leaders who have been stewards of these lands and waters since time immemorial and continue to do so today. We recognize that this land acknowledgement is one small step towards true allyship, and we commit to uplifting the voices, experiences, and histories of the Indigenous people of this land and beyond. We will strive to be honest about our past mistakes and bring about a future that includes their people, stories, and voices to form a more just and equitable society. Now I'd like to have staff on this webinar introduce themselves. Then I will give a brief presentation on the purpose of this meeting, and then we will move into discussing the draft recommendations. When we have about 5 to 10 minutes left in the meeting, we will wrap up comments and I will provide a quick overview of our next steps. With that, I would like to ask some of our panelists to introduce themselves as I call on you. Brandon.
Hello, thank you, Corey. My name is Brandon Williams. I am the project manager tasked with implementing 1724 with the Washington State Department of Health. Thank you.
Thank you, Brandon. Shauna.
Good evening. I'm Shauna Fox. I am the director for the Office of Health Professions.
Thank you, Shauna. And Harold.
Hello, folks. I'm the executive director of behavioral health programs. Professions. Professions.
Thanks, Harold. We do want to note there are several more DOH staff on the webinar, including the program managers for all impacted professions and representatives from customer service. But in the interest of time, we will not have everyone introduce themselves. If you'd like to contact any of the program managers, Their contact information is on the second to last slide of this slide deck. Before we begin, we want to provide some basic instructions for how to interact with Zoom. Along the bottom of your screen, you should see a control panel similar to this. On the far left, you will find a button to mute and unmute yourself. There is a video button, but we do have video turned off by default for this meeting. Towards the middle, you should see options for the question and answer box and the chat box. We do ask if you have a question to please put it in the question and answer box. That just makes it easier for us to find your questions, as the chat can sometimes move really quickly. And then on the right, you should have a button here to enable closed captions. And then there is a button called reactions, or potentially, depending on which version of Zoom you have, it may just say raise hand. But in either case, this is how you would raise your hand. We are also providing American Sign Language and Spanish interpretation for this meeting. The ASL interpreters are pinned to the Zoom window. If you do not see our interpreters, please put that in the chat and one of our staff will correct the issue. If you'd like to switch your audio to the Spanish interpretation, click on the globe-shaped icon. Excuse me, click on the globe-shaped icon in the bottom right of your screen that says interpretation underneath it and select Spanish to hear the translated audio. I would also like to remind everyone, if you're a fast talker like me, please try to speak a bit more slowly to make things easier on our interpreters. Also, as I mentioned, video is turned off for attendees by default. If you need access to share your video, please put that in the chat and we will enable that feature for you. Now we have a few things we'd like everyone to keep in mind during this webinar. First, please be mindful and respectful of all attendees. Please raise your hand if you want to speak. And when you do, please state your name and if you are representing any organizations or groups. If you would prefer to provide written comments, you can enter them into the chat, or you can email us at 1724publiccomment@doh.wa.gov. Oh, and I'm sorry, I'm seeing a question in the chat about the mute and unmute button not being visible right now. When we get to the speaking portion, I will enable that for you. Sorry about that. We also wanted to highlight that we are considering all of the recommendations presented today, but we may modify the recommendations based on what we hear today and in our survey. And finally, for the purposes of this discussion, we just wanted to remind everyone the bill defines behavioral health provider to include social workers, marriage and family therapists, mental health counselors, substance use disorder professionals, and psychologists. Now for a couple of brief slides on why we are hosting the feedback sessions and how the information we learn will guide our future work. As we mentioned in our listening sessions, behavioral health is a central priority for the department. We recognize the shortage of providers and the impacts that is having on access to care, facility staffing, and public health overall. The department recently adopted a transformational plan to re-energize our commitment to health for all, including a strong emphasis on behavioral health. Washington has had a shortage of behavioral health providers for many years, and the pandemic made those struggles worse, highlighting the need to increase the behavioral health workforce. In the 2023 session, the legislature passed Second Substitute House Bill 1724, which makes a number of changes to behavioral health licensing regulations. We are here today regarding Section 5, which gave the department the directive and resources to perform a detailed review and work with interested parties to come up with recommendations that increase the behavioral health workforce through improved licensing requirements. Department staff reviewed and analyzed the comments we received, performed additional research where needed, and developed the recommendations we are here to discuss with you today. We had excellent participation in our listening sessions, and we truly appreciate your candid responses and all the written comments that we received. This image is called a word cloud, We used qualitative data analysis software to review and categorize all the comments and generate this image. The terms you see on the screen are categories we grouped comments into. The larger the word or term, the more times we heard those comments. So as you can see, the barriers we heard most often relate to supervision requirements, knowledge and skills-based exams, poor communication on behalf of the department, and the length of time it takes the department to approve a license, among the others. We used this information to guide our work as we drafted our recommendations. Our discussion today will help us determine which recommendations may have the greatest impact on reducing barriers, which recommendations we should move forward with or recommend to the legislature for action, and identify gaps in areas for additional work as we move into our 2024 phase. We also want to make you aware of other process improvement projects the department has begun with the shared goal of reducing timelines. Many of these projects were started before the passage of Second Substitute House Bill 1724, but align with our efforts. Shauna Fox will give us a little more detail about these efforts. Shauna?
Thank you, Corey. So these efforts, as Corey said, have been underway in some cases prior to this bill passing and in some cases after it started. But the first one I'm going to talk about is the psychology credentialing pilot, also known as Project Pathway. This is a pilot in which we changed the structure of the way the department is doing licensing. And for psychology, in response to a lot of our constituents complaining about timelines and customer service and psychology, we have combined our customer service and our program office together. And we are doing credentialing of all psychology applications under one team. So it's both changed the sort of makeup of the way that the work is done, but also the philosophy of how we are doing the work. And so we're really concentrating on helping psychologists to navigate our process, making sure that they have a single point of contact or a team that they can contact in order to overcome any barriers associated with our credentialing. And this has been really successful. Another strategy that we are using is looking again at some of the pending, all of the pending applications that have been sitting in the queue for some time, and going back, reaching out to those applicants and making sure that we understand what they need in order to be successful. And this has really been very successful, both in improving our customer service experience for the folks who are trying to get licensed, but also reducing timelines from the time folks are applying until when their license is issued. And we've eliminated our backlog of folks who are waiting to have their applications reviewed by the board for the first time, which was an area where we had identified a clog. So there's a lot of things that we've learned from this pilot. The pilot is going to run at least through at least through December of this year. And we're hoping that we're going to be able to apply a lot of these lessons across other professions in order to continue to streamline our efforts and to improve our customers' experience. A second project that we've been working on is an independent third-party review of our credentialing practices. So this is a review that was done by a consulting group called First Rule Group. The final report has not been issued yet, but this was really a process improvement effort to look at all of the ways that we manage our credentialing work from the time that the applicant begins to fill out their application until a credential is issued. So some of the efficiencies that we think this will bring to us are in the area of increasing the use of our online applications and otherwise just making the process more efficient. We're looking forward to all of those results from that report, which is still pending. We're also working with the Governor's Results Washington group, who have been involved both with our Project Pathway and with the efforts of the third-party contractor who is doing our process improvement. And we're hoping that we're going to continue, as we continue to work with them, we'll continue to make more improvements to the customer experience and to the timelines for credentialing. And finally, many of you are probably aware that we have a very old licensing system, and we're in the middle of a long awaited renewal of our system, where we're going to be getting a new licensing system known as Helms. that will both make it easier for customers to apply and also easier for our staff to interact with the data that's in the system to allow us to have better data and better outcomes for our customers. So those are the processes.
Thank you, Shauna. The department has also identified some changes and new tools we can implement without rules or legislative changes. We are working with our communications and design teams to develop useful, accessible graphics to support applicants. We are scheduling virtual meetings, much like office hours, to provide technical assistance and create more opportunities for program managers to engage with licensees. Also, we heard during our listening sessions that some patients who are either temporarily in Washington or who have recently moved to Washington are struggling to find available providers to continue their health care while in Washington. Establishing a continuity of care policy would allow patients to continue receiving care temporarily from their out-of-state provider until they can establish care with an in-state provider or return to their home state. We are also working to establish a process for automatic re-reviews for all behavioral health professions based on the lessons learned from the psychology pilot program that Shauna discussed a moment ago. This has been highly successful for psychology in reducing the time an application spends in pending status. So we're expanding this process to the other behavioral health professions. And I just want to clarify, we received some questions after we discussed this on Tuesday's presentation. So I just want to clarify that at the moment, we are just expanding the process of automatic re-reviews, not the entire project pathway that Shauna described. Project Pathway has several other components that are still kind of going on and gathering data, and we will consider lessons learned from those components in the future. We also have a couple internal process changes which apply to specific professions. For master's level counselors, we are establishing a review process for indirect supervisor approval. In some instances, an approved supervisor is unable to sign off on hours due to no fault of the supervisee. So this process allows for supervisees to get approval from another member of the agency who has knowledge of the experience hours. We have also heard that HEALWA, a resource for providers to access databases, toolkits, ebooks, and more, does not have sufficient resources relevant to these professions. So we are requesting additional resources to support these professions be added to HEALWA. For substance use disorder professionals, we are working to update materials and provide clarification on our website about which professions have the ability to provide SUD services in their current scope of practice. And finally, for substance use disorder professionals and agency affiliated counselors, we're establishing a pilot to trial a process change in application review that would allow us to review applications with criminal history to determine which ones need to provide court records and request those from the applicants, rather than the current process where all applicants must turn in court documents before we review. The goal is to reduce the burden and cost to applicants in gathering those documents. I know that was a lot of information, so please put any questions you have into the chat or Q&A, and we will do our best to respond as quickly as we can. I do see one question right now. What is a re-review? That is just where we will, if an application is staying in pending status for a while, we'll take another look at it. And if there's still things missing, just reach back out. So it's just us trying to be a bit more proactive about making sure that you've received our previous communications and are aware of what is going on with your application. And if that doesn't answer the question, please go ahead and put another one in there. All right, we will spend the remainder of our time discussing the recommendations we have drafted thus far. I will give a brief overview of our draft recommendations and rationale, and then we will open the floor for about 15 minutes of feedback on the proposed recommendations on that slide. We will repeat this for each slide. At the end, we will have an opportunity for open comment, and you can provide additional feedback on the draft recommendations or any other thoughts or feedback related to this effort you may want to share. At any time, you can put comments in the chat, but please remember to reference which draft recommendation you are responding to so we know what to tie that comment to when we analyze the feedback. Once the sessions conclude, you will receive a follow-up email with a link to take a survey on the draft recommendations. And finally, we do want to note our draft recommendations relating to psychology are slightly different than the other professions we will be discussing, since psychology is regulated by a board rather than the department. We are presenting these draft recommendations to gather your feedback, and we will share everything with the examining board of psychology. The board will discuss the draft recommendations and the feedback we received at their board meeting on September 29th. They will also take a formal vote on the draft recommendations at that meeting. If you'd like more information on the upcoming board meeting or how to attend, please contact Nancy Delgado or Zach Patnode. Their contact information is listed on the second to last slide of this presentation. All right. This slide and the next slide are our initial draft recommendations for legislative change. As a reminder, this is the first round of recommendations, and we will be doing another round next year. So for master's level counselors, we are considering creating a pathway for students completing their practicum to continue providing services to established patients. We heard comments during the listening session that there can be a significant gap between a student completing their practicum and the degree being posted. Until the degree is posted, the department cannot complete its review and issue their full license, so they have to stop providing care, which can cause access to care issues for established patients. We are also considering recommending that Washington adopt the Social Work Compact as an alternate pathway to legal practice in Washington. We recognize the value of compacts in expanding the workforce. However, we recommend it as an alternate pathway and that a Washington-specific pathway be maintained because the compact requires elements that the department recognizes as barriers to entry or remaining in the profession. We are also considering a recommendation to remove restrictive language that requires a portion of the supervised experience for LMFTs to be under a marriage and family therapist that has 5 years of experience, and allow any qualified marriage and family therapist to supervise. We heard during the listening sessions that finding approved supervisors for marriage and family therapists was a significant barrier. RCW requires a supervisor to have at least 5 years of experience for a portion of the hours, and licensees and applicants reported it was difficult to find supervisors who meet this requirement. This change will remove that barrier and increase the number of professionals that are qualified to supervise. This change applies only to marriage and family therapists, as the bill itself modified the standards for social workers, and mental health counselors have different requirements that do not present this barrier. There are also rules that would need to be adjusted to align with this effort, which we will get into in a later portion of the presentation. And finally, we are considering a recommendation to remove continuing education requirements in statutes. This is in alignment with a rulemaking recommendation for all behavioral health professions, which again, we'll get into when we discuss our rulemaking proposals. With that, I'd like to open the floor for feedback from you all. Please raise your hand if you'd like to provide verbal comment on any of these recommendations. And if you would prefer not to have your voice recorded, please feel free to put your comments in the chat. Gail, go ahead.
Thank you. Thanks, Corey. Gail McGaffick. I'm here today on behalf of Fresenius Medical Care. Fresenius operates 26 freestanding kidney dialysis facilities in the state and provides care to over 2,300 Washingtonians. Fresenius is in very strong support of adopting the Social Work Compact as an alternate pathway to legal practice in Washington. Because Fresenius operates in many states, it would be a great service to their patients if they were able to move social workers to areas of greatest need quickly as circumstances require. And I think the pandemic really illustrated that. So we very much appreciate having this on the list and just wanted to affirm our support. And thank you very much.
Thank you, Gail. Is there anyone else who would like to raise their hand and share? I do see one question of how many folks are in attendance. Right now we have 33 attendees, and I will see if I can figure out how to make that visible. But if not, I can follow up too at the end of the presentation. And it looks like next we have Adam. Oh, I'm sorry, Adam. I just muted you by accident.
Okay, there we go. Okay. I just want to comment on the psychologist recommendations. The second one, which was establish an easier pathway to access licensure for non-APA. Yes, is there going to be something more specific in that recommendation? Yeah, how's that going to play out exactly?
I believe that's one of our recommendations for rulemaking for psychology. So there would be a whole rulemaking process that would involve, the work with interested parties and a formal public hearing. So the detail of it would be worked out in that process.
I see.
So
any specific recommendations should probably wait until the rulemaking process.
Yeah, you would absolutely have opportunities to engage with that and try and work on the language with our psychology team if they choose to move forward with it.
I see. Okay, thank you.
No problem. Next is Jeremy.
Hi, Corey and team. For the record, my name is Jeremy Arp. Pronouns are he, him. I'm the executive director with the National Association of Social Workers, Washington chapter. We had given some comments the other day, but wanted to reiterate that NASW supports the compact and the development of possible alternative pathways regarding the ASWB exam. We have some concerns, which we expressed at the last session, about the removal of continuing education requirements beyond the statutorily required named continuing education for social workers and behavioral health professionals. As outlined before, NASW creates several guiding documents for the social work profession, including our Code of Ethics, Standards for Professional Continuing Education, and our policy document, Social Work Speaks, which has specific recommendations for policy development in regulation and licensure that do include professional continuing education as a requirement for licensure. That said, during the last session, Corey, you provided some research that kind of pointed to where the recommendation came from, and just wanted to kind of outline that although the articles kind of suggest the way that in which CEUs are delivered or continuing education is delivered seem to have an impact on whether the continuing education made a difference or not the CEU training requirement in itself. And so we would very much prefer to have the CE requirement continue, one, to make sure that professional social workers, marriage and family therapists, and licensed mental health counselors have a pathway to make sure that and the public knows that those folks engaged in professional practice are engaging in continuing education to make their practice more relevant over time. As you know, there's technology improvements, there's new modalities, new methods of practice, new technology, and regulatory changes that are all part of continuing education that informs competent practice. And so having that requirement beyond the suicide prevention and treatment and ethics and health equity requirements, we would very much like social workers and others to have that self-directed continuing education requirement that makes folks better at their jobs. So that said, we would caution against making that recommendation to remove the continuing education requirements in statute. Thank you very much.
Thank you, Jeremy. I do see a question in the Q&A. Are there plans to explore alternative pathways to licensure that don't include an exam? Then there's some more information. We will get into that on a future slide. We are looking at the exams and discussing options about that. We just need a little more time before we could come to a conclusion and make a recommendation. All right. Next, I see Rhonda.
Hi, good afternoon. Rhonda Hoff, Yakima Neighborhood Health Services. We are a community health center with 10 primary care sites in the Yakima Valley, providing street outreach, mobile units, and also 150 units of permanent supportive housing. And I wanted to speak to the issue about agency affiliated counselors. As you know, we aren't currently allowed to hire agency affiliated counselors because the WAC restricts us from using them. We currently do employ substance use disorder professionals, and we found them to be invaluable in our integrated model of patient-centered medical care. We have several job applicants who are AACs and who would be of significant workforce multipliers in our setting. We provide, in addition to primary care, we also provide Medicaid foundational community supports, which include supportive housing and supported employment, primarily for chronically homeless individuals. We see patients and clients every day living with enormous trauma, abuse, and neglect. And our behavioral health team has been running on half steam for the last 4 years. The AACs will help us catch up to these families and needs. Our ability to employ AACs like we use our SUDPs provide the ability to support people in these housing and employment programs. And if they're not engaged on a very regular basis, then we risk their ability to run on us. We need the increased workforce to support them in transitioning to improved health and self-sufficiency. I've heard some of the concerns from the licensed behavioral health agencies, and we have also lost providers to private practices. Our two settings are different, but hopefully the AACs will want to work in one of our two settings rather than see this as a stepping stone to private practice. But I don't really see the competition as being a reason to not allow FQHCs to employ agency affiliated counselors. As I mentioned, we've had vacancies for 4 years now, and our ability to employ agency affiliated counselors would be a workforce multiplier to serve both Medicaid and the uninsured residents in our communities. Thank you.
Thank you, Rhonda. Anybody else who would like to raise their hand and share? All right. So here we have a few more recommendations for legislative changes. For master's level counselors and substance use disorder professionals, we are considering a recommendation to remove the limitation of renewals for master's level associates and substance use disorder trainees. This limitation creates a barrier, has a negative impact on equity, and does not improve patient safety or access to care. For substance use disorder professionals, we are considering a recommendation to remove the restrictions on trainees that limit them to working only in substance use disorder agencies. This creates a barrier by limiting the number of training sites available for SUDPs and thereby limiting the number of SUDPs available to serve the public. For psychology, we are considering a recommendation to establish an associate level credential. As unlicensed trainees, there is currently no direct regulatory oversight for these individuals who are providing services to the public. Establishing this credential would create that oversight. Furthermore, our initial research into other states shows many have found value in having this training level credential, and having such a credential will allow these associates to bill insurance for their services. For agency affiliated counselors, we are considering a recommendation to modify RCW to allow them to practice in federally qualified health centers. While federally qualified health centers are not regulated by the state, they are regulated by the federal government with similar structure and oversight to a state licensed behavioral health agency. This change would allow expansion of the workforce and increase access to services for patients. Okay, now we'd like to open the floor up again for your feedback. Please raise your hand if you'd like to provide comments on any of these recommendations. Yes, Joan.
Hi, I'm sorry, I missed the beginning of the meeting, so I was in the chat sending questions instead, but I'll just say them. So ASAM is another barrier for clients and professionals, you know, on the regs right now, say you have to be an SUDP or an SUBDP under supervision. And so if you're an LMHC or LSW, all of that they can't, but they can do other drug and alcohol assessments. So for many years, I have harped on this issue, and I'm hoping during this time of change and looking and thinking outside of the box that we can maybe consider getting rid of the ASAM and going back to more a simplistic tool that doesn't take so much time with the clients and allows all of the other credentialed persons to perform that assessment as well. And then I put also another question in there about where is the insurance companies and Medicaid on reimbursement for us? Are they in alignment with us going down the path as we change credentials? And I mean, I know it won't be perfect, but I'm saying if this gets changed and we create these new credentials, is that going to affect our billing? Because there has to be a lot of changes in that and reimbursement as well. And those may be too big of questions for this, but I wanted to bring those both up. Thank you.
Yeah, I'll do my best, and I'll call on my phone a friend of Brandon to help me out. So as far as reimbursement, that is not within the department's authority to address. So we aren't necessarily dealing with that issue. Brandon, do you have anything you want to add on the functional side of that? And Brandon, if you're speaking, you are muted.
I couldn't get my mouse on the mute button. I apologize. I don't have any additional information to share on that. Corey, I'm assuming that's something that we can capture in a potential report, but falls slightly outside of the 1724 potential jurisdiction. Potentially, I'm not sure. I'd have to look into it a little bit more, but it might maybe something that we can consider for the report portion of this to kind of have a potential ripple effect, but I don't have any direct information on that at this time.
Okay, thanks, Brandon. And really quick, Caroline, it looks like one of our interpreters is having a technical problem. Can you try and help her out?
I see that, and I will try to as a co-host. We'll get it handled.
Okay, thank you.
Corey, may I just provide a little information to a previous question about the exam in relation to what's on our screen? So there was a question earlier about some of the disparities acknowledged for the social work exam, and Corey did a great job explaining that we're looking into all options and gaining information on that. One thing we're recommending to hopefully reduce some of the issues associated with that is the first recommendation on the screen, which is removing the number of limitations for renewals for the master's level counselors and associates. Hopefully with removing that limitation for the LICSWA and the LASWA, which is the Licensed Advanced Social Work Associate and the Licensed Independent Clinical Social Worker Associate, that can provide some relief for some of the exam barriers that we're getting information on while we continue to build information for appropriate action.
Thank you, Brandon. And just wondering if you had anything to add about the comment about the ASAM?
I'm gonna see, Ted, do you have information on that? I know that the SUD world is a little bit more your expertise. So do you have any input on that?
Yeah, I don't actually. I don't think that's something that we specifically looked at for the other types that were going. I'm trying to scroll back up to the comment here to look at it. So the ASAM is kind of the federal standards. It comes out of SAMHSA, and so that's typically what we've adopted. So I don't think there's been much discussion about looking at some of these other options. And I think you're looking at it specifically for like licensed counselors to be able to use these other ones, but provide equivalent assessments to the SUDPs, correct? It's really something we would have to look into further for something like that. It could also bleed into the agency licensing that for SUD agencies about what they'll accept as well. So it's kind of it's a bigger picture. It's going to take a little bit more work to look into.
All right, thank you, Ted. We have a question. Can you provide clarification on the removal of the MHP credential and how that impacts supervision of staff, SERI guide, and if staff will need to apply for and pay for an additional AAC? Ted, is that one you can respond to, or do we need to follow up on that?
Nope, I think that's one I can meet you. Okay, so the MHP was never really a credential. It was never a license to practice. It's an agency designation. It's essentially what they use as shorthand for someone who's qualified to provide a certain level of services, so they can assess and diagnose and you know, treat these identifiable mental health conditions as a part of the scope of practice for their underlying credential. The problem came up with the MHP was that we had listed a bunch of specific credential types, and the registered agency affiliated counselor with a master's degree and 2 years of supervised experience. So for the rest of them, we could just look and say, you have this credential, you're good to go. For the AACs, we had to do more research, we had to get more look, and then they had to like kind of go through a review process to say, yes, you are qualified to do this work. That was actually contradictory with the statute for the AACs, because no AACs should be able to assess and diagnose, regardless of what the facility rules did to expand that to make them an MHP. So to fix that, that's how we implemented the new licensed AAC and the certified AAC, so which both can assess and diagnose within their scope, and they'd also changed the definition of what an MHP is to include all the previous license types that were on there, and now it's more specific to the licensed and credentialed AACs. So it doesn't necessarily remove it or take it away, it just kind of modified how we look at it to say that you have to have one of these specific credential types, rather than you can have this one with these extra kind of educational and training requirements on top of it that were built in. If that's correct, you cannot apply for the MHP. It was really just a designation. You have to have an underlying credential to get it. So before, you could be a licensed mental health counselor and you would be considered an MHP and you could get designated with that. Now you don't have to send in that form. You are considered an MHP if you have the credential that qualifies. So if you're already a licensed mental health counselor or a psychologist, you are an MHP. You don't have to be designated by the department. And it's something you were never really able to apply for. It was a one-page sheet that said, I have this credential and this is my experience, and they came in.
Thank you, Ted. Joan, go ahead. And Joan, if you're speaking, I'm showing that you're muted on your end.
Sorry, I said thank you, Ted, and everybody else for taking on this huge project that has been much needed. And I've been in the field, I'm dual credentialed SUDP and LMHC, but for over 30 years. And there's some people that nose are out of joint, you know, because of the changes and the lowering the credentials. But you know what? I'm old, but I can deal with this because we need to do this. My concern about is minor, but I think it's, well, maybe not so minor. I think it's important to bring up on our counselor disclosure. What I would ask right now, I'm a private contractor, plus I work in community mental health as well. And so, well, we use students and interns and master level and, you know, agency affiliate, all that. My concern is that I think we could need to get clearer on our counselor disclosure. Normally, if I am evaluating and diagnosing a client in mental health, they typically don't have huge issues if I tell them they're going to be working with a master level student or a bachelor level under supervision or something, not too many people squawk about it and say, I want a fully licensed person with a master's degree. But I think just to do right by, our end and ethical and all of that, I think we need to have a discussion or point out about counselor disclosure when that comes up, that we are clear on that, on what level of professional that they're working with, right? Rather than most people don't, and clients don't understand what an agency affiliated is versus somebody else, and all these different acronyms and credentials. So I just think that we have to be clear on that up front with clients on informed consent or counselor disclosure somehow, and say, depending on your need, you'll be linked to the person that can help you with this level of care or whatever it is. Okay. And then the other thing that I know you guys can't answer, again, on the Medicaid reimbursement and insurance, and I get it's a whole other department and ball of wax, but so I'm thinking ahead and thinking, well, so we go do all this wonderful stuff and then find out there's a whole billing hell out there, that's going to say, well, we're not going to reimburse, kind of like, you have to be licensed clinical social worker for Medicare, but not Medicaid. And I'm like, if they aren't doing something on their end, it would be nice just to, even though it's not your department, you guys got a lot on your plate, if somebody could look into that and just see, is that going to be looked into as well? Otherwise, it's kind of, aren't we doing this all in vain, right? Does it make sense?
That does make sense. Thank you.
Okay.
We'll see what we can do to just connect with our colleagues. And I saw your hand is back up, so I just want to see, is that a old hand or okay? Thank you, John. Would anyone else like to raise your hand and share on this slide? Yes, Sarah, please go ahead.
Hi, thank you so much for having this, and we appreciate taking the feedback. I'd like to support what was previously stated about the billing piece. I don't know if there's been any communication with the HCA about how this will impact, like the SERI guide, and how this will impact if the MCOs have been informed kind of of this change, and if there's preparations as well, because it's hard for agencies to switch or like go back and bill. And we've gotten more feedback that MCOs are expecting like they can't go make retro changes to contracts without forward moving. And so if we have to go back and make alterations along those lines or get feedback or guidance after the fact, it becomes very difficult. So I just want to like reiterate that too. And then I have just a few more questions about like the licensed versus registered AACs. Is now an okay time to ask that?
Yeah, I think that's fine.
So we've been reaching out to DOH and about kind of what the changes are. I understand that the MHP, we did submit to DOH when we were working on getting the MHP approved, and we've asked for like kind of guidance on what the new change will be and how current AACs, like if they need to apply to get, and I am sorry I was late for this meeting, but will they need to apply to get either licensed versus registered, or what does that look like? Because the feedback we're getting from DOH is that it's only a paper application. There's no way to submit online right now, and that there's one person who's processing like 400, of these applications. And so we're just curious how this impacts staff currently trying to get in to get their AAC.
Sure. I'm going to go ahead and call on Ted to help me answer this one.
I already got my hand up. Now I got to figure out how to take it down here. So we're trying to work this out with the AAG and get a little bit of legal guidance. But the way we're going forward with it is that if you have a current AAC, you will at some point need to apply for the licensed AAC for that going forward. It's not going to transfer or just automatically slide over. You need to apply. We need your transcripts from the school, and the application has an attestation in there for your supervised experience for the 2 years for that already has it now. We're also working on the electronic application, maybe another month or so before that's going to actually be up and running for people to go in. What we are doing is working on a policy that's going to allow a grace period for anyone who was previously designated as an MHP AAC to be able to keep working as a registered AAC while this change is going on for like the next year or so. And when you come up like maybe 3 months before your renewal, then you would apply for the licensed AAC. So that you wouldn't have to pay twice. Like you wouldn't have to jump in, do it right now, get your new credential, and then have to renew it again on 6 months on your birthday. So that's the plan going forward for that, is they can kind of sit tight and keep doing the work for now. The policy, we're still probably about a month away from getting that out as well. But that should be coming, and then these people will be able to just kind of apply as they expire because they're already designated as an MHP. If you had anybody that was in here that was not quite designated before we stopped doing the designation, they're going to need to apply. If you hire somebody new right now, they need to just apply for the licensed AAC to be the MHP for that going forward. So that should hopefully give a little bit of a breather for at least the people that were previously doing the work and give them a bit of time to get the new credential going forward. But it will be a new application. They will have to apply, they'll have to get the transcripts and get that stuff sent in.
Perfect. I really appreciate that. And I'm glad the grace period is going to be like a year or something that will help a lot. I guess my question is, when was the cutoff period for the MHP? Because we had quite a few staff that were in like the app, like in the application process, and then they got notified well after the fact. I would say months after the fact that they wasn't there. So I'm curious what your cutoff date was for it.
I believe it was July 24th was kind of the date that this all came around. I think it was actually technically the 23rd, but it was a Sunday. So it was July 24th when that came around. It was the same date that the licenses went online with the paper applications for that is when everything came around. So that's probably when it was. I don't know for sure. I'd have to double check and see. I don't work in that unit that does it, so I'm not really familiar with what happened.
Okay. If we can put something on the guidance paperwork, that would be awesome. Like when you put it out for when it's effective, that would be useful for us. I really appreciate your guidance on it. Thank you.
Sure. You're welcome.
Right. Thank you, Ted and Sarah. Any other hands on this slide? Okay. I am seeing a question of what document clarifying are we referring to regarding which professions have the ability to provide SUD services in their scope. I think we've just had some confusion recently about which professions already have this in their scope. So I think we need to put together some documentation and update information on our webpage just to make that more clear. I'm not sure that I can name the specific document. Ted, I don't know if there's anything you'd want to add to that.
Not really. It's just something that we're looking into.
Okay, thanks, Ted. Alrighty, so this slide and the next two slides are our initial draft recommendations for rule change. For all behavioral health professions, as we defined it earlier in this presentation, we are considering eliminating continuing education requirements except those required by statute. Studies have shown the prevailing types of CE that are available, the classroom or lecture style CE, are not effective in improving practice or patient outcomes. These requirements can be a burden on licensees and are not equitable in their impacts, so we recommend removing them. We have recommended maintaining the health equity CE and suicide prevention CE as required by statute, as those requirements are infrequent and there are free or low-cost options for completing them. For master's level counselors, except social workers, we are considering allowing professional experience to substitute for practicum requirements. During the listening sessions, we heard significant concerns from applicants with many years of experience that they were having to go back and complete the required practicum. This creates a time and financial barrier for applicants that does not improve patient safety, equity, or access to care. We have excluded social work professions from this recommendation as the department rules do not require a practicum, but rather those professions do a practicum or internship as part of their educational program. We are also considering lowering the years of licensure requirement for licensure by endorsement from 5 years to 1 year. Upon reviewing our WACs, we determined this creates a barrier that does not improve patient safety, equity, or access to care. And we believe if the applicant has met all the licensing requirements to become licensed and has been safely practicing for a year, requiring them to wait an additional 4 years is unnecessary and burdensome. Finally, we are considering amending rules for marriage and family therapists to align the definition of equally qualified licensed mental health practitioner more closely with other master's level counselor professions. This is in line with our recommendation to modify the statute for marriage and family therapists, and we recommend making similar adjustments to the rule. We would also like to note this change, the change in statute would be required before we can make the rule change. Okay, now we'd like to open it up again for feedback from you all. Please raise your hand if you'd like to provide comment. And first up, we have Renee. And, oh, Renee, your hand just went down. Did you? All righty. Anyone else who would like to share? Oh, no problem, Renee. Okay, I'm not seeing any hands, and it looks like Ted's answering our only questions, so I'll go ahead and move us on. Here we have recommendations for rule changes for substance use disorder professionals. We are considering removing the requirement that supervisors be on site, allowing for remote supervision. This requirement creates a barrier to meeting supervision requirements and negatively impacts equity, so we recommend eliminating that requirement and expanding supervision opportunities by allowing remote supervision. However, for patient safety, this recommendation does not apply to the first 50 hours, which are required to be face-to-face. We are also considering lowering the years of licensure requirement for licensure by endorsement from 5 years to 1 year. As I mentioned, for master's level counselors, we determined this creates a barrier that does not improve patient safety, equity, or access to care. And we believe if the applicant has met all the requirements to become licensed and has been safely practicing for a year, requiring them to wait an additional 4 years is unnecessary and burdensome. We are also considering modifying the coursework requirements for SUDPs. So any applicant who graduated from an SUD counseling program with a degree does not need to have their coursework reviewed. Any program offering a degree will meet the requirements, so reviewing this coursework in detail unnecessarily slows down the review and approval process. We will continue to review coursework for applicants that have not received a degree. We are also considering eliminating the 7-year cap on supervised experience earned. We heard during the listening sessions that applicants were losing hours they had completed because they had occurred too long ago. There are many reasons a person may need more time to complete supervised experience, and this limitation can cause inequities and barriers to becoming licensed. This change also brings SUDP regulation in line with other healthcare professions. Finally, we are considering reducing the years of practice requirement to become an approved supervisor so that any SUDP who has been safely practicing for more than a year can become a supervisor. We heard during the listening sessions that finding approved supervisors was a significant barrier, and this change would allow more SUDPs to become supervisors. All right, now we would like to get your feedback. Please raise your hand if you'd like to provide comments. While I'm waiting for hands to go up, I do see a question in the chat Are you looking at pathways for qualified foreign trained professionals to get licensed? That is actually a component of the legislation, so we are looking into that, but we did not have enough information to make a recommendation on that this time around. But we will keep looking into it as we move into our 2024 work. And I'm seeing a question, I think, Ted, this will be for you, regarding the first one on the slide. Do licensed professionals need additional supervision to meet SUDP requirements? If so, this is a barrier, expensive, and difficult to find supervisors. Ted, can you respond to that?
Yes, well, they need actually additional education and experience in taking the exam. So if you're already a licensed counselor, a psychologist, or a couple other professions, you can go through our alternative pathway, but you still need 15 credits specific to SUD treatment from like a community college or a university if you don't have that within your previous education. And then you need 1,000 hours of supervised experience as an SUDP trainee in an SUD agency. So you can't do it in private practice. You have to do it within an agency going forward. The agencies are, they're always looking to hire people. They provide supervision as part of employment. So getting a supervisor to do the SUDP work should be fairly easy because you have to go through one of these agencies to be able to do it. The problem is that you can't do it within your private practice. So you have to do more work above and beyond what you do in your, counseling work to be able to get the SUDP credential.
Thank you, Ted.
Mm-hmm.
There's also a question. I'm a foreign trained AAC at the moment. Will I be able to be a licensed AAC? I suspect that we can't answer that without knowing the regulations of the country where they were trained. But Ted, is there anything you'd add to that?
That's kind of what we're looking into is we have to find a way to determine the equivalency for it. There are, degree equivalency groups that will look at foreign applications and how they relate to it, but the applicant typically needs to pay for that out of pocket. So we're kind of maybe looking at some alternative methods for that, but we don't really have any good answers for you at this point.
Ted? Would anyone else like to raise their hand and share? Okay, we will go on to our next grouping then. Here we have our draft recommendations for psychology rule changes. As a reminder, these recommendations have not been voted on by the psychology board yet. We will share your feedback and the board will discuss and vote on these recommendations at their September 29th meeting. The department recommends the board consider modifying the rules to establish an easier pathway to access licensure through non-American Psychological Association accredited programs. We've heard a number of concerns with APA accreditation during our listening sessions, and we've also learned several other states already allow alternate accreditation through non-APA entities. Also, we have found a growing number of schools have either dropped their APA accreditation or have announced their intention to let it lapse. Under current rules, there is a detailed list of requirements, so we recommend creating options that streamline this process and reduce the additional scrutiny applicants from these institutions undergo. We also recommend the board consider reducing the number of residency hours required. Current policy allows for applicants from online and hybrid programs to substitute face-to-face meetings in lieu of residency, but many applicants from such programs are unable to complete that amount of face-to-face educational meetings due to resource restrictions or geographic location or other restrictions. Reducing the number of residency hours required would help lower barriers for applicants from hybrid or online programs. This would create a pathway to practice for those applicants and improve equity in licensing. We also recommend the board consider allowing online-only schools that meet qualifications established by the board to qualify for licensure. Educational programs are offering more and more online opportunities, and studies show online education, especially at higher levels, is equally effective as in-person programs. Furthermore, online options create more equitable opportunities for students from different backgrounds. We also recommend the board consider increasing the number of courses that can be completed outside the doctoral program. Some doctoral programs do not include everything required for licensure in Washington, forcing the applicant to take additional coursework. Current regulations only allow for 2 courses to be taken outside of the doctoral program, which serves as an insurmountable barrier for students from programs that fall as little as 3 courses short of our requirements. Finally, we recommend the board consider modifying the licensure by reciprocity and endorsement rule to establish different standards for different lengths of practice. During the listening sessions, we heard several comments about providers having been in practice for a decade or more, but having to go back to school or otherwise duplicate efforts to meet certain requirements. This creates a barrier for applicants from out of state. While the board did significantly expand the states considered equivalent to Washington in their June meeting, there are still some states that are not considered equivalent, and creating standards that reflect the reality of the applicant's professional experience would reduce barriers and help get experienced out-of-state applicants into practice quickly. All right, with that, we'd like to open the floor again for feedback from you all. Please raise your hand if you'd like to provide verbal comment on any of these recommendations. And as always, if you want to type it, feel free to put it in the chat or the question and answer box. Not seeing any hands yet. I just want to give it another minute just in case. Okay. Thank you all. So we are embarking on several changes and are recommending more, but there is still work to do to increase the workforce and improve the credentialing process. These are items you helped us to identify during our listening sessions that the work group, which includes the department, the Workforce Training Board, and the Examining Board of Psychology, are still actively discussing. We recognize that there are more barriers to address that are not mentioned here, and we will be doing more work with interested parties in 2024 to continue this effort. Also, we wanted to discuss the knowledge and skills exams. First, we want to recognize this is a very important issue, and we are working hard to determine the best path forward. We heard a lot of comments in our listening sessions about the social work exam bias and disparate outcomes, and some comments that national exams in general are biased and should not be used. We've considered a number of options, including replacing the exam with an alternative, but current statute requires the exams to assess applicant skill and knowledge. We're looking at all of our options, but need a bit more time to look into what other states are doing, research alternatives, gather data, and explore the consequences of any potential change. We also want to acknowledge we heard many comments about provider pay and reimbursement, unpaid internships, background check fingerprinting, and fee refunds. The department does not have the authority to affect provider pay or reimbursement, nor can we require internships to be paid. We also discussed posting fingerprinting cards online, but that's controlled by the Washington State Patrol and is not allowed. If you are an in-state applicant, you do have the option to go directly to the State Patrol and have your fingerprints done by the State Patrol rather than sending the card back and forth with the department. However, this option is not available for out-of-state applicants. Regarding licensing fees, we heard a couple of different comments. One was regarding submitting the incorrect application type and refunding fees when that happens. If the applicant notifies the department before we have processed your application, we can redirect the fee you paid towards the right application. However, if we have already processed your application, we cannot refund or redirect the fees. The other comment we heard was that licensing fees should be refunded if the application is denied. In this case, we cannot refund the fee because the application fee covers the cost of reviewing and processing the application, which was completed, even though the application was denied. Okay, we do have about 40 minutes left that we've dedicated for public comment. So if you have anything you'd like to share, please raise your hand, be it about one of the recommendations or something else related to this effort. And if you've already shared, do feel free to raise your hand again. You are welcome to share more. Gail, go ahead.
Yeah, thanks, Corey. Hi, Gail McGaffick again, and just speaking personally here. I just wanted to say I am so impressed with what I've heard today and all the hard work that you've done and your colleagues. I am particularly taken with the improvements to the credentialing process and the out-of-the-box thinking you all have done to help psychology. And it just seems to me that you're forming kind of the groundwork for other professions as well. And so I just thank you. It's been very fascinating and educating to be able to listen to all of this and everyone's comments. And I'm very grateful. Thank you.
Thank you, Gail. Anyone else who would like to share? All right, I will move us into next steps then. After we have gathered your feedback, we will review and analyze the results and adjust the draft recommendations as needed. The Examining Board of Psychology will meet on September 29th to discuss and formally vote on the recommendations pertaining to psychology. We will be finalizing our recommendations and the presentation over the next couple of months, and then we will present our recommendations to the legislature on or around November 1st of this year. In 2024, we will schedule more time to hear from you all and identify barriers that still need work or new barriers that we may not have previously identified. We will present additional recommendations to the legislature in November of 2024. Department staff have also put together a website for behavioral health related legislative implementation. It provides high-level information on all the bills listed on the page and includes a lot of information from our 1724 work, including the recordings of the June listening session and slides from today's presentation, and we will post the recordings of today's presentation on this site as well. Our recordings are posted in English, Spanish, and American Sign Language. And if you would like a link to that, Caroline has just added that link to the chat. And before we conclude, a big thank you to our interpreters and captioners. Thank you for your support and helping making these meetings more accessible. And thank you to all the department staff working hard in the background to run the technology, provide technical support, and answer questions in the chat and the Q&A. Thank you all very much for your participation and for sharing your feedback with us. If you have any questions or comments you'd like to send us, please email me at 1724publiccomment@doh.wa.gov. And if you have specific questions about one of the professions, you can contact the appropriate program manager listed on this slide. We look forward to our continued work together. Thank you all again for being here and spending your evening with us. I hope you have a great evening. And again, we just look forward to working with you in the future. Thanks, everybody. Have a great night.